To chair the session, I would like to invite Dr. Aarti Bansal. She is a senior consultant physician of Ghaziabad. And Dr. Pankaj Agarwal, he is a very senior endocrinologist. I would like to request the chairpersons to kindly introduce our speaker.
Good evening, friends. I invite Dr. S. Chakravarti, who has been past president of API Noida, to speak on the topic evidence-based management of fever or duration. Welcome, Dr. Chakravarti.
Hello. Good morning to everybody. At the outset, I would like to thank API Ghaziabad and UP API chapter for giving me an opportunity to speak on this in front of this August gathering in just 12 hours notice. So, and the slides have been shared by Dr. Virendra Singh, who is chairman of API, UP chapter. Before I start, I would like to little bit of interaction. I did a small study on aceclofenac. It's a 100-patient small study on aceclofenac in patients of dengue fever. And the outcome of the study was that there was no fall in platelet count at all after giving the aceclofenac. It was given for pain, body ache, joint pains, and there was no fall in platelet count with that aceclofenac. This was the outcome of the study. So you can use any of these NSAIDs. It usually do not cause much problem. Do not use aspirin as such. Okay. Thank you very much. Today I will be dealing with the evidence-based management and short duration of fever in OPD basis. So we all know that majority of these fevers from past day 1 to day 3, 5 are being treated mostly by the patient self or the patient's neighbors or the chemists. So we stand as a physician nowhere, and most of the time patients do not come to you with it. Nowadays, after this COVID, people are coming, or even after the first episode of fever, they are coming nowadays. So we have to see what exactly, how to manage the first 2-3 days of fever. Thomas Sydenham wrote in 1600 that the fever is a mighty engine which nature brings into the world for the conquest of her enemies. So if somebody is having fever, yes, it may not be infection, but fever is a fever. It is abnormal to body. So you will have to somehow investigate or treat it. So in recent times, the fever becomes a product of the disease. You should bring down the fever as well as you should try to treat the infection. And we have plenty of technologies these days. Even the PET scan, as I said, can be utilized to diagnose the fever. Whenever a patient is coming to you in the first few days of fever, we mostly write at the corner of the prescription AFI. So AFI can be localized to organ systems or non-localized. So instead of writing AFI, you can write AUFI because you really don't know whether you have differentiated it or not. Unless patient is presenting with you severe throat pain and you examined that there is a tonsil there, then it is tonsillitis. Otherwise, most of these patients, you don't get any sort of evidence. So it is better to write AUFI rather than writing FI. So in these conditions, we have to see which way we are heading to. If there is a tonsillar enlargement, if there is any ear discharge, okay, fine, we are heading towards the ENT side. If it is a cardiovascular, which may be very difficult in first 2-3 days, but if you are getting any signs, yes, you have to go ahead. If there is a involvement of the liver or hepatobiliary region, you localize these. So there are plenty of causes of fever, and if you are able to localize, that's well and good. So you need a stepwise approach with careful interpretation, not only of the cause at that point of time, but also you have to consider the possible exposures the various risk factors, patient may be immunocompromised, as I said, the clinical features and basic laboratory data. If patient is coming to you with some kind of data, because most of the patients get it done right in day one. The acutely ill or immunocompromised patient or pregnant woman or patients with dialysis or patients admitted in emergency, yes, you need a higher investigation. So what does this AUFI really constitute of? Malaria, yes, very likely possibility. You may not get any signs and symptoms apart from fever with chills. Dengue fever, you all of us know that there is some joint pains or body ache, nothing else. The chikungunya patient may not have joint pains right at the beginning. Rickettsial infections, scrub typhus, enteric fever. Enteric fever patient may develop fever and present with fever, only fever and nothing else. Leptospirosis, jaundice may not develop right at the beginning. And seasonal influenza, we all know it is usually during this period, the seasonal influenza can develop. So influenza-like illness, most of these influenza-like illness are the first one to present with high-grade fever, severe joint pains, body ache. This is one presentation. And the second presentation is that not much of sign symptoms, only fever, mild cough and cold. But most of these are usually subsides by 5 to 10 days and the patient go back to work. So it is a dictum in the clinical practice that any fever which continues beyond 10 days, then it is not a routine viral. Then you'll have to investigate. So after a week of fever, you have to investigate definitely for enteric fever, malaria, UTI, and all these. So there is some protocol. If the patient coming to in OPD basis and there is a patient coming to in emergency basis. So as we have heard in the previous lectures that there is no guideline as such mentioned, but now, yes, there are certain guidelines from ICMR, there are certain guidelines from Ames and Tropical School of Critical Care Medicine and all these. They have now been given some guidelines. If a patient present with fever coming to you in emergency, a patient coming to you in emergency will not come with a simple fever. So patient definitely may have some kind of evidence of sepsis. Please follow the sepsis protocol then accordingly. And if the patient is having some localizing signs, you will have to treat this localizing signs accordingly. But if the patient doesn't have any of these, then you consider a day of fever. Patient coming to you day 1, day 2, wait for some time, investigate maybe after 2-3 days. So defer investigations and antimicrobials both. Just wait and watch. Second, the patient's day 3 or day 4, then you go for some little investigations like CBC, you can go for a malarial parasite or a urinalysis. But if the fever is still persisting and it has gone to 3 to 5 days, yes, you can go for a culture and then subsequently decide about the antibiotics. So tropical fevers management guidelines are definitely nowadays there, and they have approach. It is a syndromic approach as they have told it. So we have an undifferentiated fever, a fever with rash with thrombocytopenia, fever with acute respiratory distress syndrome, fever with encephalopathy, and fever with multi-organ dysfunction. So all these they have classified right at the beginning now. So if there is an undifferentiated fever and you are not getting any specific signs and symptoms in the body as well as in the history, then consider malaria, scrub typhus, leptospira, typhoid and dengue, and of course the viral illness, influenza like. But if you have rash, you know all these fever with rashes cause the dengue, the meningococcemia or the rickettsial infections. So if patient presenting with fever with ARDS, then consider falciparum malaria is definitely one of them. And then there is a whole lot of causes which are mentioned here. Fever presenting with encephalopathy right at the beginning. Okay, there may be some kind of encephalitis or meningitis of different origin. Cerebral malaria can also be one of the features. So fever with multi-organ dysfunction, all those patients who are presenting in emergency can present you with multi-organ dysfunction. This can be because of the bacterial sepsis, dengue, scrub typhus, and many other host of infections. So we have to have an algorithmic approach. So a patient who is coming to the emergency, you first of all stabilize the patient with fever. Then consider the symptoms of SIRS, systemic inflammatory syndrome, and then see the vital functions. If there is a focus of infection which has been identified, treat accordingly, whether it's a pneumonia, whether it's a pyelonephritis. But if there are no signs and symptoms, you reassess and then consider various other factors like local factors, like there may be an endemic of dengue in that particular region. If the patient has fever with rashes, then leptospira and jaundice, if at all, is there. So all these things needs to be considered in an algorithmic approach. So this is what is being mentioned here. You go ahead with this algorithmic approach and go on reassessing the patient every day. There are certain rapid tests which has come, and many of our are using these rapid tests in our clinic. I have seen many of the physicians using these rapid tests for malaria, for dengue fever, for many other investigations. They are all doing it. Yes, you can go ahead with the rapid test. If the fever is with encephalopathy, as you can see, there may be other causes. You have to rule out the hypoglycemia, but these are all features, or all whatever is to be done in the emergency basis. So if the patient is having seizure, definitely we go ahead with various whole lot of investigations for seizure and ultimately treatment according to it. So in all these, whatever is the cause of these, do not use steroids right at the beginning. That is the main dictum. Do not use any kind of antibiotics right at the beginning at maybe in day 1, day 2. If you are able to localize something, then you please go ahead. So the BMJ has published one article saying that you can assess and initial management of acute undifferentiated fever in tropical region. This slide is pretty good. You see how they have diagnosed. It's an acute febrile illness. If a patient presenting to you in OPD, acute localized infection, you have localized the infection is in the respiratory or urinary tract and gastro anywhere, then you go accordingly and proceed. But if you have not able to, yes, it is an AUFI, that you have undifferentiated illness, treat it as malaria or non-malarial, one of these. So if it is a malaria, okay, you treat it. If it is a non-malarial AUFI, smear and rapid diagnostic test is negative, then it opens up your. So now you have a viral, you have a bacterial, and you have a parasitic. In viral, please consider arboviral infection and influenza viral infection. And if it is a bacteria, then you consider bacteremia because of many reasons, or it's a zoonotic infection like spirochete, leptospira, all these things. This slide is pretty good. It just simply summarizes what you need to do in first 3 to 5 days. And if it is a parasitic, then this hepatic amoebiasis or the schistosomiasis, all these things are coming. So you just proceed in a stepwise manner. So what you exactly need to know, the malaria and arboviral or the other dengue, enteric or zoonotic diseases such as scrub typhus are common causes to consider in the patient with acute fever, and no localizing symptoms, especially in this tropical region. So if you do not have you have no localized region, then you consider all these. And then you proceed with a stepwise approach with careful interpretation of local disease pattern. So first you consider these, and then you see what exactly is the local disease pattern which is going on. And the request for testing malaria and full blood count if patient has a undifferentiated type of fever. And the presumptive antibiotic therapy may be started if you have a suspected bacterial zoonosis. So you may not start azithromycin right on day 1, and you better wait for some time and see which way you are exactly heading to, and then you can proceed. Otherwise, if you continue using like that, we have already heard that indiscriminate use may cause bacterial drug resistance. So what we said, that there is no guideline. No, there is guideline. Aajkal hai, there are guidelines, ICMR guidelines for managing acute fever. So they have been divided into tropical fever, seasonal fever, monsoon fever. Suspect malaria in all cases of undifferentiated fever. Then you have a viral influenza-like illness. If the rash is present, please rule out drug allergy or infectious mononucleosis like picture, or exanthematous viral illness like measles, rubella. And primary and secondary dengue may be accompanied by rashes and polyarthralgia. So these are the tropical and seasonal fevers which are there. If there are hemorrhages there, then you know you are more localized towards it. Scrub typhus is also one of the causes. Leptospirosis, typhoid and community acquired bacteremia, if at all are there, you are able to localize some signs and symptoms, please go ahead. hepatitis E, or chikungunya and rheumatic fever and tuberculosis, of course, at a later stage. So empiric antibiotic treatment, whether it is required or not required, it is limited to severe sepsis, or you have localized some kind of infection, then only you proceed. And reassessment within 48 hours to be more specific about the antibiotic therapy. So principles of empiric therapy, we have already heard about it. So I'm not going into the details of that. Corticosteroids is definitely not recommended in the treatment of acute undifferentiated type of fever. So the management, how will we proceed? Day 1, day 2, differ. Don't give any antimicrobial. Day 3, day 4, to go ahead with some investigations like complete blood count, malarial parasite, or rapid diagnostic test, which we are normally using in the clinic. And if the suspicion is high, then proceed accordingly. From day 5 onwards, you go ahead with the cultures and more specific investigation. Day 7, you go ahead with the X-ray chest and ultrasound abdomen. So note down this guideline. This is not my own guideline. This is a guideline from ICMR guideline. So proceed accordingly. So we are not just following this, but definitely we should follow this. So second guideline is the Ames guideline. So one is ICMR guideline. This is the Ames guideline. So Ames guideline says acute febrile illness, which refers to the patient presenting with acute onset fever lasting more than 2 days, but usually less than 14 days. And the patient presenting with AFI should be assessed for organ dysfunction. Due to organ dysfunction at presentation, and symptoms and signs suggestive of sepsis should be ruled out. So undifferentiated, uncomplicated fever, basically. So then you go ahead with a rapid diagnostic test for malaria and distinguish it between malarial versus non-malarial cause of AFI. So there are various other factors involved in this. Now, these patients, undifferentiated fever, fever with no localization, the ICMR Ames guideline. You start with ceftriaxone. This is what exactly we are doing in various nursing homes and the hospitals, plus injection or oral doxycycline. As you can see, 100 milligram twice daily, or azithromycin 1 gram daily. This is at admission in any of the hospitals, nursing homes, everywhere. Outpatient, if clinical condition permits, wait until the availability of reports. If strong suspicion of bacterial, start cefixime 200 mg twice daily into 5 to 7 days, or azithromycin 500 once daily for 5 days. This is exactly all of us are doing for a very long time, and we do have an experience quite a lot with the same kind of protocol management. Now Ames has validated it. Send blood culture before starting antibiotics in all patients, de-escalate based on specific results. Later on, I would like to know the opinion of the House regarding oral doxycycline right at day 1, whether we should use it or not. So acute undifferentiated fever pool in the emergency department. This is from the Ames Rishikesh. So they have a profile. The profile of the patient has been presented. I will not go into the detail. So the study highlights that defer unnecessary investigation and antibiotic usage in any of the AUFI patients. So the roadmap for this, another updated article which has been published from API only, we say how to manage about the acute undifferentiated fever. So the febrile conditions are characterized by fever or less than 2 weeks without organ-specific clinical features. Malaria and dengue are the most prevalent febrile throughout the year, as Dr. Anupam Prakash also said. So the last set of slides saying how to proceed with the management of AFI in a stepwise manner. So a patient who is coming to you with 2 to 3 days of fever, see how you proceed. So first, local prevalence data. So this time dengue is going on, COVID is going on. So we will consider this as first. Seasonality we will see. We will see the exposure to the animals, whether they are not or it's there. We have to see the comorbidities. Patient is diabetic, patient is non-diabetic, some cardiac problem, patient is pregnant, patient is an elderly one. Then proceed with the step 2. Evaluate this patient whether the patient is toxic or not. So SIRS symptoms are there or not. Then you rule out, then examine the patient. See whether these patients are having some kind of rashes, then your diagnosis goes towards that side. Or the patient has specific symptoms, let us say some UTI, then you proceed accordingly. So then you go to the step 3. If there is nothing, go ahead, test for malaria. Rule out whether there are signs and symptoms of influenza are there or not. Then you go to the step 4, evaluate for non-malarial acute febrile illness. So you go for urinary examinations, just finishing. And then finally, you have to go for an empiric therapy. So here they say empirical treatment. So this is the point of concern, that empirical treatment with doxycycline for patients with undifferentiated fever and negative rapid diagnostic malaria is an option for clinician. So whether all of you are using doxycycline right at day 1 or not, the guidelines are there from Ames. So positive blood culture, review the diagnosis and evaluate other infections if fever is persistent. So there are various initial steps. Most of this I have already told you. And just to summarize this, that you have to assess the patient regarding the direction which way the patient is going. And you can start with an antibiotic if you think it is a bacterial sepsis or some kind of bacterial infection, then only you start. And doxycycline, all of us have to think about whether we should go ahead with the doxycycline right at the beginning, as nowadays various guidelines do say you can proceed. I thank you very much for your kind listening.
Thank you, Dr. Sabal, for justifying the topic in such a short notice, extremely short notice. Thank you. You offered me a topic and I could not complete it in 1 month, and you did it in just 1 day. Fever is I think, the most difficult aspect of physician's practice, and it is the most important as well. Yes. So how to deal it in acute onset fever, how to deal it in a case with long duration of fever are 2 different aspects. So the house is open for discussion. Any question, please? No question, no confusion.
This shows that you have
Please.
told so nicely.
Any role of empirical? Okay, fine. So right. So now the question is, we were doing the similar kind of practice earlier also. Here, the guideline directed therapy, if you have to follow the scientific, all those data which has been compiled by Ames and other places, ICMR, this is no longer valid, that you give empirically so it is better to avoid, but rapid diagnostic test and all others, you can also proceed and find out whether it is heading towards that. But right at the beginning, anti-malarial, no. Yeah, it is there. It is there. Yeah. In fact, many of the patients who are admitted in the hospital, fever is not going down. We do try that. That is there. But in terms of guideline, which now they have specified, though it is not indicated. Any role of colchicine? Colchicine, we have been using for fever, as you said, not at the beginning. If the patient is admitted in the hospital, yes, you can try. Even in COVID also, we have tried colchicine. Many of the patients have been given colchicine in COVID also. Yes, now they have said, yes, it is legally safe. This is the guidelines now they have specified. This is from ICMR Ames. So we have to follow these guidelines.
I would like you to please make a comment upon validity of Vidal test.
Validity of Vidal test comes only after 1 week, and it has to be matched along with the presence of a culture and the serological test typhoid, which we are.
Which is not done in 99% of cases.
Yeah, just singly on the basis of Vidal, definitely not. There should be 2 paired references. One single. Give you an.
Rising titers.
Rising titer.
Rising titer.
Increasing titer. Yes, sir.
And double typhoid.
Single
जो होता
typhoid
रहता है,
result also does not give you any. There are most of the time it is false positive. And this season we have seen plenty of cases of dengue fever coming with the typhoid positives, which are mostly false positive. Hmm? But this, yeah. Yeah, and this. Most of the patients who admitted this season with typhoid positive, we have sent cultures right at the beginning. This year specifically, we have seen that the cultures did not grow any enteric. No salmonella was grown in that. Typhoid first 1 month, definitely IgM will continue to be positive. Thereafter, IgG will become positive.
Two small things I wish to add for fever management, which I have used in my practice. One is for dehydration, we should be extra sensitive, especially with dengue, where liver function is damaged partially in many cases, and there is severe gastritis. And people, when they are at home, keep on taking more and more paracetamol, not eating and drinking anything. So the easiest way to find out, to have an idea about the fluid deficit is take a lying down blood pressure and pulse, and then standing immediate pulse and blood pressure, and then after 3 minutes. And many a times this gives a very good clue to how much fast rehydration you have to do. And usually intravenous ondansetron and then electral helps. Number one, this was my observation. Number two is that when the patient is asking and doing doctor shopping, कि डॉक्टर साहब कब उतरेगा, उनको दिखाया, तो coolly make the patient sit comfortably and say कि देखो हमारा काम है खतरा नहीं होने देना. जैसे दीपक की लौ है, हमने हाथ रखे हुए हैं, अगर मुझे भी बुखार होगा तो मुझे नहीं मालूम है कब उतरेगा. जब तक कि इतना वक्त गुजर जाता है, मेरा फैमिली मेंबर या मैं खुद या कोई भी डॉक्टर, तो फीवर के बारे में जो अनसर्टेनिटी है, पेशेंटली वेट करने से, साइंटिफिकली चलने से वो ओवरकम होगी और आप सेफ रहेंगे. यही हमारी जिम्मेदारी.
Thank you.
Thank you, Dr. Chakravarti, and thank you both the chairperson, Dr. Pankaj and Dr. Aarti. Now I will request both the chairperson to give moment to our speaker, Dr. Chakravarti.